Now, when we apply all of this to the data that we have now, we can look at it this way. You've got the test that initially came out here. This was at April 8th article looking at the performance of nasopharyngeal swabs and seeing that the sensitivity was as low as 56% to 83%, right? So we're missing half the cases on a clinical basis for this. And that here it says for that patients with typical symptoms who have a presumed COVID prevalence of 40 to 50%. Well, man, the only place where there was a presumed COVID-19 prevalence of 40 to 50% was in just a few skilled nursing facilities, right? So this recommendation is only applicable to, it's not generalizable to the entire populations. It was generalizable to a few skilled nursing facilities. But it was an admonition, an admittance, I should say, of understanding that a negative test result should be interpreted with caution and that repeat testing was needed, right? It was recognizing this is a crappy test. You need to trend the test to really understand it. And I can tell you, I was seeing notes from providers upstairs saying, nope, test was negative, 99% chance that it's negative and will never turn positive, or it's not going to be positive. It can't possibly be that. And it was missing that the false negative test results were much higher. And it's still an attitude that I've seen carry on. Here's a test looking at rapid point of care testing, right? So this is looking at IgG and IgM, right? So again, we're going away from diagnostic active disease to recognizing that a patient was previously infected. And these studies are small, only 49 patients, right? So, and only 22 tested positive based on PCR. So when they looked at this, using the rapid test, only 8 of those 22 were correctly positive. So the sensitivity was only 36%. So some of these blood tests are so shitty that they're only capturing a third of the patients that have the disease. And the specificities are okay at 88%, but it's not great. So given the low sensitivity, they recommend to not rely on antibody rapid test results for public health measures, such as community screening. So while we're racing to get a bunch of tests made, we have to ask ourselves, what are the characteristics of those tests? And do we understand how those characteristics translate to their utility, both on a diagnostic level and on a surveillance level? Right? So again, this shitty test with sensitivity 36% is no shittier than a troponin that we use currently to diagnose heart attacks, right? So trend analysis still has a benefit here for the patient as well as for the population. The only problem is we don't have enough tests to carry that out in a way that would be meaningful for either group. Diagnostic performance of COVID-19 serology assays ranges. This is a study that they looked at a number of 9 different rapid detection tests. And based on the different manufacturers, they said, well, the sensitivity is anywhere from 72% to 100%, which is fantastic, right? 100% would be great. Specificity ranges of 98% to 100%. Again, these are different manufacturers. They were all small studies for the most part. There were some studies that had 150 cases. There were some that only had 20 cases. So again, we're early on in this, and there are a lot of businesses that want to compete with each other. And so, of course, as soon as they can be 100% or close to 100%, they're out there, trying to sell their studies. But it's important, again, for us to be consumers of this information in a way that's knowledgeable and makes sense, and that we understand what we're doing with that. And again, you can use a crappy test. You just have to be able to use it repeatedly to make sense of it to some degree. And then here's another study that came out of the Journal of Medical Virology, looking at the high false negative rates that were reported with PCR tests, right? And then the need for urgent, accurate, rapid testing methods. But again, the testing strategies that they're looking at here are looking at immunologic responses to disease and looking at patients that already had the disease. And here in this version of the test, they have a test that was used on 397 patients. So this is one of the bigger studies. And they found it to be 88% sensitive and 90% specific. So it's going to have a false positive rate of around 12%, and it's going to have a false negative rate I'm sorry, false positive rate around 10% and false negative rate around 12%. So this can be used in a diagnostic way to help determine whether or not a patient has been tested before. If they test positive, it's likely that they actually have the disease. But we're still missing the very clinical features that are important, which is, are those antibodies protective against disease, and are those antibodies specific? And this is what really came up out of this study and the previous study here, was recognizing that some of these false positive test results are occurring because they're overlapping with antibodies that form to people who already had a different form of a coronavirus, not necessarily even SARS, but just a regular common cold. And that was related to one of the other human coronaviruses that are present. So there's still so much more information that we need to understand about what this immunologic response is, whether or not it's a stable response, and whether or not it's actually protective. And this is the big feature of that, is that just because you have IgG and IgM present, it doesn't mean that the quantity that is present is sufficient to shield you, right? So you could be holding a shield. So pretend you're in a sword fight and you're holding a shield. Well, if that shield, no matter how strong the metal is, only covers the diameter of your hand, then that's the only level of protection that you can expect from it. And if the shield, covers your entire body, then you're like, great, right? Like that's a kick-ass shield. These features of understanding that are still yet to be determined. Those are based on studies that are called titers, where you measure what the concentration is of the antibody and whether or not that antibody is active enough and if it's stable enough to stay in your bloodstream to be a big shield, or is it just a tiny little shield that indicates, yeah, you were infected. It's like a marker that you were infected. It's a small scar, an infection scar, so to speak, but it's not necessarily one that's a protective one. And so these are things that we're still, obviously working on and trying to determine. And we've had these problems before with other viruses. It's not like we've had a SARS vaccine from the previous outbreak, or a MERS vaccine from the previous outbreaks, or even an HIV vaccine for all the decades that we've been studying HIV. There are a number of vaccines that have been trialed and tried, and those that are promising to come up again, still in the HIV world. But it's in some instances taking decades, and those are related to features of that particular virus and its pattern, and a number of other things that can occur. But viruses mutate, which is what makes it difficult. They're moving targets, so there's still a lot more that needs to be done for us to get to a point that we're going to be confident in how we're explaining this to people, and being able to provide a level of confidence that the public really wants. And it's understandable why they want that and what the emotional need is for that on so many different levels, both the confidence of being able to return to work and spend time with family members and so on and so forth. But nonetheless, we're still obligated to provide a level of information that's actionable and accurate, rather than necessarily sway our decisions based on what we want. And so again, here's another test that looks at the appropriate use of COVID-19 testing, and really kind of looks at the issue that, you have these tests of very high specificity, but only moderate sensitivity. And again, we were finally getting these numbers coming out where they weren't available to us 2 months ago. 2 months ago, I couldn't get these numbers whatsoever. And finally, these are being published, and seeing that sensitivities, for PCR testing was 63 to 78%. And not in the high 90s like everybody wanted them to be. And that here, again, you can see that they're far more accurate if they come from lower respiratory tract than they do from the upper respiratory tract. And that's kind of what this paper really kind of gets into and discusses. So, right, in the sampling technique, you're just taking a sample, you're putting it through the nose, you're collecting some virus on that sample, as well as a bunch of mucus and a bunch of other crap. And then you are finding a way to break those cells up, and it extracts the RNA, right? So there's this point from A to B is a very complex point of like how you extract RNA from this sample. And then how you have enough of that sample that's functional and maintains its structural integrity, that you can then add a reverse transcription to it. And that adding a reverse transcriptase to it involves a lot of other features of adding additional nucleotides and additional material and concentrations that will be sufficient to do this. And then that once you've done that, from that clone DNA, that you've now are able to use a DNA polymerase and a probe with a additional unit that's kind of what's called a quasher that kind of quashes the signal to only display probe when it's under the amplification process, and then you continue to run cycles of amplification until you can actually measure a level after so many cycles that is positive, and versus those that we define as anything below that threshold is negative, right? And this is how you get those different curves of people that are on this distribution curves. And so there are a lot of features to each one of these steps where things can be done poorly and errors can occur. In addition, this also shows you that in each one of these steps, this is why it's time consuming and takes a great degree of effort to do this, as opposed to the lateral flow assays that are done with looking at IgM and IgG. Those tests are easier to do. They're more simple to obtain. They can do them as home tests, but again, they lack certain features of sensitivity and specificity that make it as useful for making the diagnosis. And again, on a population level, it makes it difficult because we're still in a low prevalence state. So in this low prevalence state, again, the differences between a shitty test and the great test are minimal. Not minimal, but they're diminished. And therefore, we're going to be in this kind of position until we see the prevalence increase. This is just a very complicated way of just showing that in general, when we're running tests on people, if I don't think a patient has a disease, the pretest probability is low, I usually don't run a test on that. I'm not trying to find a needle in a haystack. And at the same time, if something walks like duck and sounds like duck, quacks like duck, it's a duck, right? The pretest probability when it's high, I don't do testing for that either, because there's no need to do that. I already think the patient has a disease. I'm going to make my decisions to treat or whatever based on that. So it's really, in general, this group that's between these thresholds of no testing where we actually apply our tests. And when we do, you have this kind of helpful rubric here that kind of shows you, again, if the likelihood ratio is 1, it's unhelpful. If it's 2, it's supportive. And if it's 10 or greater, it's diagnostic, right? And this is how it affects our thresholds to treat. And the same thing occurs with negative tests here. So 0.5 and less than 0.1 is kind of where we use for diagnostics there. So you can kind of see, like, you're looking for numbers in those likelihood ratios in those areas to help you. And that kind of pretty much sums up like how we do diagnostic testing, how it applies to COVID-19, and how mitigation strategies are informed based on all this.